If you're like me, I'm guessing you spend a lot of time ignoring anything other than mean arterial pressure in your patients with shock. Today, we're going to abandon this bad habit together. First, remember that normal diastolic blood pressure is somewhere between about 60 and 80 millimeters of mercury for most patients. So diastolic pressures in the 30s to 50s are by definition abnormal. Most patients with truly abnormal values will be somewhere between 30s and 40s, and sometimes you'll even see the value fall into the 20s. There are three main determinants of diastolic blood pressure, and rather than trying to memorize them, it's better to understand how blood flows when the heart is not pumping, which is the diastolic phase. So there must be some other forces that generate blood flow during this period of time. The first and by far the most important factor determining diastolic blood pressure is the total peripheral resistance, or the peripheral vascular resistance. Patients with vasodilation, which is common in distributive shock, such as septic shock, have low diastolic blood pressure, and that's essentially because blood is traveling in a larger or wider circuit than normal within the arterial system. The second force dictating diastolic blood pressure is the compliance or the stiffness of the aorta and the conducting arteries. In order for blood to flow during diastole at all, the aorta and the conducting arteries have to distend during systole so that they can recoil during diastole, so that kind of moves the blood forward. You can imagine if those arteries were stiffer, their ability to recoil would be less, so stiffer arteries would generate a lower diastolic blood pressure. The third factor, which is probably the least important, is the heart rate. A lower heart rate will give you a longer time in diastole, longer time for that sort of blood flow runoff to occur, and will generate a lower blood pressure, lower diastolic blood pressure. Generally, this is only relevant at really extreme bradycardic conditions, but as you can imagine, if you had vasodilation and a low heart rate, that could be very problematic in the management of shock. One really important consideration before I go is that if we're talking about measuring diastolic blood pressure accurately, we probably need to be using an arterial line, especially because as our blood pressure gets lower and lower, the non-invasive cuff will be less accurate for systolic and diastolic blood pressures, because you have to remember that automated cuffs only measure the mean arterial pressure, and then they derive a systolic and diastolic pressure from that. They're not directly determined. It's not like when you're in med school and you were measuring it with a manual cuff. To sum it all up, peripheral vascular resistance is by far the most important component of diastolic blood pressure. So when you have low diastolic blood pressure, you should presume that there's vasodilatory shock until proven otherwise. You should still, however, remember those other forces that will have an impact on your diastolic blood pressure, such as stiff arteries, which can make conduction of systolic cycles into diastole less effective and thus giving you a lower diastolic blood pressure. And also remember that heart rate can play a role, and a lower heart rate will generate a lower diastolic blood pressure. Does this change your approach to understanding shock or the cause of shock in your patients? Let me know in the comments.